Director uh, uh, Ratish, other friends and colleagues. Today's topic, we have two presentations. The first presentation focusing on the drug price control, its rationale, its structure, and as well as its shortcoming to achieve its primary objective of the price control, that is to ensure uh, affordable medicines or access to affordable essential medicines in the country. But the scope of the price control goes beyond the essential medicine. The provisions allows the government to regulate price of any medical product, any medicine which comes under the purview of Drugs and Cosmetics Act to fix the price, uh, uh, as and when it is required. So using these, during these last 10 years or something, government used these provisions, especially the para 19, to fix the prices in various ways to ensure access to the medicines at an affordable price. So having said this, without elaborating further, uh, I would say why we require a mechanism like drug price control. It is precisely because our health system is organized in such a way that most of the people go to the private sector and using their own out-of-pocket expenditure or their own savings or their own money to seek the healthcare services, including buying the medicines or medical products. So as a result, this is the only way or effective way to ensure access to affordable medical products or medicines by putting a ceiling on the um, ceiling on the maximum retail price of the medical products. So that's why the DPCO is very relevant in the Indian context. Still, 80% of our 80% of our inpatient care is happening in the private care sector. Similarly, the outpatient care also, huge number of people goes to the, 70% of the inpatient goes to the private sector. Similarly, the 80% of the outpatient goes to the private sector. And all these people use their own money for buying medicines. Most of these people. So therefore, the drug price control is basically is the is a unique instrument in the Indian context. Okay, so you may not require an drug price control order in a country like Sri Lanka, where most of the people goes to the public healthcare system. But even the Sri Lankan government found out that there is a huge profiteering on certain medicines which are not otherwise available in the public care system. So they also impose that price control on certain products. So having said this, let me now uh, request Dr. Shaktivel Selvaraj to make the presentation. Shakti, floor is yours.
Shaktivel sir.
Just a second. Just a second. Just want to check is the slides clear now? Is that visible to everyone?
Yes, sir. Yes, sir. Slides are visible, although not in the presentation mode. Yeah.
That's fine.
But they are.
Is that in a presentation? I'll just go to the presentation mode.
Yeah, sir. Now it's in the presentation mode, sir. Perfect. Yeah.
All right. Okay. All right. All right. Thanks, Chair, for the introduction, brief introduction. And good afternoon, everyone. I hope I'm audible to everyone. It's a pleasure and honor to be here at this webinar. I just want to thank the organizer for hosting this webinar, especially the Inter University Center for IPR Studies. Given that I have about 20-25 minutes in terms of presentation, what I intend to do, I have about 40 slides or so. What I intend to do is to touch upon some of the slides and then leave some of it not to be discussed at this point in time. But if you find this useful, please do use it as you wish. All right, let's begin. Now, we are all aware of the fact that India is a global pharmacy. I hope I'm audible to everyone.
Yes, sir.
Gopal?
Yeah, you are audible, sir. Clear.
Yeah.
All right. So India is a global pharmacy. This is something that we all know that India has done an enormous amount of work in the area of pharmaceuticals. We currently produce about 300,000 crore worth of medicines. About half of it, close to about 150,000 crore worth of medicines are consumed within the country, and about half of them are exported to 190 countries around the world. And these are produced by about robust about close to about 10,000 manufacturers. And we also know that close to about 400 to 500 of these manufacturers have US FDA approved plants. This is India, the only country which has the maximum number of US FDA approved plants outside US. That's running to close to about 500 or so. And then there are more than 1,000 plus GMP compliant, European Union GMP compliant or WHO GMP compliant manufacturing units in India. So the point that I'm trying to bring home is the fact that we are truly a global pharmacy. But having said that, the question is, well, we are a global pharmacy, no doubt. But the question is, does our people, does our own set of people, larger set of population have access to medicines? Unfortunately, if you look at the current evidence, a large section of our Indian population do not have access to medicines. And so what really are the factors that constitutes as a barrier to access to medicine? I think this is something that I need to start with because a lot of people may not be aware of the fact that there are several barriers, there are several factors that have been acting as a major barrier to access to medicines. One, and the first and the foremost, is the fact that our healthcare financing mechanism is unfair, inadequate. That's the first point, which I'll touch upon very briefly. I wouldn't really go into the financing aspect, just to touch upon. And then the other factor, which is very closely related to the government funding, is also to do with inefficient and unreliable procurement and logistics supply system in the government system. So that's the second set of issue that we face in the Indian context, although I'm not going to touch about these two factors. But the third factor, which is largely to do with pricing, is that what I'm going to be talking largely today. And then in addition, I'll also be talking about the role of patent in acting as a key barrier to access to medicine. Although there are other factors which act as a key barrier, I'm not really going to touch upon those issues, including issues around inappropriate or irrational use of medicines prescribed, dispensed and use of medicines, and of course the issues around inadequate funding for research and neglected disease conditions. So those are essentially the three 5 or 6 critical barriers that India and in India we face in terms of access to medicine. In terms of financing, some of you might be aware of the fact that currently India spends about 4% of its GDP on healthcare. So if you, in terms of the per capita spending, overall health spending, if you look at in India, in terms of per capita spending, it's close to about 4,500, about three years before. So if you look at 4,500 is the per capita spending, but if you look at the per capita spending of 4,500, close to about two-thirds of that money comes from the households. Just about close to about 1/3 comes from the government. Now, look at the medicine spending on the other hand. If you look at the medicine spending, that's close to about 1,500 rupees per capita. If you look at the medicine spending in India, households on an average, if you look at the per capita spending, spend about 2,200 rupees per capita. Now, this is at the household level. As far as government is concerned, they spend hardly, in fact, less than about 100 rupees per capita for procuring medicines. So look at the kind of imbalance that exists in terms of who buys medicines, who procures medicines. A large part, in fact, not even 10% of medicine spending is done by the government, but about 90% is actually spent by the households themselves. So as a result, if you look at the government spending on healthcare, as I said, about 10% or so, but it also again varies between state to state. Some of the southern states, such as Tamil Nadu, Kerala, spend on an average about 10 to 12%. But if you look at the other states, even including states like Punjab, where it's supposed to be one of the Punjab, Haryana, and many other states which are supposed to be economically advanced state, and you would expect them to spend more, but unfortunately, even they spend very little on healthcare, number one, as a whole, and then also on medicines. As a result, you find that households, as I said, spend a lot of money from their pocket. But having said that, 2 or 3 states, if you leave out 2 or 3 states, such as Delhi, Tamil Nadu, Rajasthan, and to some extent Kerala, if you leave out these 3 or 4 states where they not only spend relatively adequate spending on healthcare, but also on medicine procurement, but mostly, if you look at the other states, because the government doesn't spend much money on healthcare, especially on medicines procurement, households end up paying a lot of money on buying medicines from the chemist shop. As a result, you see that the share of inpatient, outpatient, as well as total drug spending as a percentage of households out-of-pocket payment ranges anywhere between 35 to about 55-60%. So that's a large share in terms of the households spending, which goes into buying medicines. All right. So that's the first and the second point that I wanted to talk about in terms of financing, healthcare financing, and logistics supply system. Let me move on to the core issue that we're going to be focusing here is about the pricing. Now, look at medicine pricing. Now, unlike other market, why is that most countries, if you leave out few countries, most countries do intervene in the medicines market. Despite the fact that look at most developed countries spend a lot of money, government spend tax-funded money on healthcare and also providing medicines, even with those robust systems, and yet many developed countries do intervene in the medicines market. So the reason for intervening in the medicines market are not one but several. Now let me give an idea about the market failure that some of you might be aware of, the fact that unlike other commodity markets, in the case of healthcare, especially medicines market, consumers lack the sovereignty. What do I mean by lack of consumer sovereignty? It really means the fact that the patient or consumers just simply do not have the kind of information that's there with the provider. So as a result, you have a huge information asymmetry between the patient and then the provider. When you have a huge information asymmetry, you would expect market to fail. And that's exactly what we are really looking at in the case of medicines market. That's one. The second point about the medicines market is, unlike the other commodities, where the demand for commodities are elastic in nature, which demand changes according to the prices. But in the case of medicines, the issue around medicines market is that it's uncertain. Number one, the demand for medicines is uncertain, and the demand for medicine is also inevitable. And if it's uncertain, no doubt, it's inevitable. I mean, we'll have to demand and then buy it. In case if you don't buy, in most circumstances, it becomes inevitable. If you don't buy, you know what the consequences are. Therefore, the demand for most medicines, especially the life-saving and essential medicines, are inelastic in nature. Whatever be the price, one has to demand, one has to buy those medicines, right? That's the second point about medicines. The third point about medicines market is, unlike the other market where consumers demand commodities or services, in the case of medicines market, demand is largely supplier induced. So it's just not the consumers who are demanding. That demand is actually based on somebody else's demand, which is essentially the supplier. The supplier here would mean the prescriber, it could be the dispenser, but ultimately it's the producer who is exerting a lot of influence on the ultimate demand. So therefore, there's a large element of supply-induced demand in the case of medicines market. The other point about medicines market is, which is something very unique, which you don't find in many other ordinary market, is that the top-selling brands are often the most highly priced. We can talk about, I mean, there are several examples. In fact, the market is awash with this kind of example of top-selling brands, often the most highly priced. The fourth and the fifth important point is to do with, we all, in fact, the drug companies often tell us that given that India has about 10,000 manufacturers, so they often tell us that there's a lot of competition in the market. But if you look at the market, pharmaceutical market is just not a single market. It's composed of about 3,500 markets, sub-markets. Therefore, our evidence shows that there's a lot of oligopoly or monopoly in the medicines market, and hardly any competition, except in few therapeutic market we have competition. But other than that, in large segment, about 75% of the market, we have either monopoly or oligopoly elements. So that's basically the major issue. And the sixth point about the medicines market in India, which is very unique in the Indian context, is the question around, in fact, half of our market, medicines market, is composed of irrational medicines and fixed dose combinations, which is a major issue. And all that put together can be treated as a huge failure in the market. Therefore, intervention in the market becomes extremely important. So as I can take you over the years, beginning from 1955 onwards, the government of India has been imposing regulation, but with some gap here and there. But a comprehensive price control on medicines was imposed way back in 1978, 79 to be precise. If you look at the drug price control order of 1979, followed by 1987 and then 1995, and then the last the DPCO, drug price control order, was passed in 2013. But having said that, I'm going to skip some of the history of the drug price control. But the point about the drug price control is that in 1979, we had almost about 90% of the entire pharmaceutical market was price control. As you can see in the second column, as you can see, both the percentage of medicines covered under the drug price control order was about to the extent of about 90%. But now you move closer to 1995, although it is about 50%, but currently before 2013, the percentage of market covered by the drug price control order was close to about 10%. So, in a sense, there was a reversal of price control over the years, beginning from, especially beginning from the mid 80s, and then it got further liquidated in the 90s, all because of the fact that we had economic liberalization and privatization. So that's pretty much about the drug price control, the history of drug price control. But having said that, just one quick point before the 2013, the latest drug price control order. Before that, one of the points that we need to also keep in mind is the fact that India used to follow what is called the cost-plus-based pricing method. What does this cost-plus-based pricing method is called? The retail price is fixed based on cost plus. You have cost, which includes raw materials, conversion cost, and other cost. And if you add over and above the actual cost, if you add the maximum allowable manufacturing expenses, let's assume that, for instance, atorvastatin, medicine used for cardiovascular disease conditions. Assuming that 10 mg was produced, ex-factory cost was about 3 rupees. According to the cost plus based method, if you apply this formula, you would expect during the cost plus based pricing mechanisms for the period before 2013, the atorvastatin 10 mg would cost about, at the retail level, about 6 rupees 60 paise. So essentially what we're saying is just the double the amount of the actual cost, which was about 3.30. So that's essentially what the cost plus based pricing, which existed before 2013. Now, interestingly, if you look at 2013 drug price control order, since many of you are aware of the fact that until about 2013, the liberalization which began in the mid 80s, which went on till about around till about 2013 or so. If you look at the medicines market, only about 10% of the market used to be price controlled. So as a result, a lot of civil society went to the court, argued in favor of bringing more and more drug prices under price control. The Supreme Court of India in 2012 and 13 requested the government of India to bring all the essential medicines under price control based on 2011 National List of Essential Medicines under price control, all essential medicines, which is about 348 medicines under price control. Although the government of India agreed to bring in all the essential medicines under price control, but unfortunately, instead of following the cost plus based method, it moved away from cost plus based method to what is called market based pricing formula. Now, what is market based pricing formula? Market based pricing formula is essentially arrived by simply taking the average prices of the retailer, looking at all the brands which has more than 1% of the market share. So, so that's essentially how the market-based pricing formula works. Let me give an example of how does this work. Now, assume that just an illustration. Now, assume that let's say atorvastatin is produced by, let's say, 10 companies. Now, as you can see, there are 10 companies. There are 10 brands, right? And then look at the market share. The market share of, let's say, Cadila is about 0.5. On the other hand, Novartis has market. This is just an illustration. Novartis, assuming that, has about 8.5% market share, and about has a 30% market share, and so on and so forth. Now, if you have these kind of element of the market, you have 10 brands, and then the market share of these are given. assuming that all the 10 brands command 100% of the market share. How are the price control worked out here? Price control of this particular, let's say, atorvastatin worked out. Now, all the brands whose market share is less than 1%, as you can see in the red color, red font, digits, all those market share and the prices will be excluded from the calculation. And as you can see, there are about 5 brands which are left. So if you take the average of those 5 brands and then calculate the average price, what you get is basically the 68 rupees. For instance, let's say atorvastatin 10 mg is sold, let's say 10 pack is sold for, let's say 68 rupees. But according all right. In case if you don't exclude all of them and you take into account all the 10 brands into account, your simple average would be about 47 rupees, 47.5 rupees for, let's say, atorvastatin 10 mg 10 tablets. On the other hand, the new formula suggests that if you leave out those 5 brands with less than 1% of the market share, what you're really getting at the retail level is about 68 rupees, right? And that's the kind of a formula that the government of India came up with, and this is something called what is called market-based pricing method. So that's one of the major limitations of this market-based pricing.
Shakti, you have 4 minutes. Could you just...
Okay, all right.
Yeah.
I'm not sure. All right, I'll try and speed up.
Yeah.
So that's one of the major issue. The other major issue in terms of the scope of the coverage is the present 2013 DPCO excludes combinations and then the additional dosage forms and strength of essential medicine. What it really means is that, let's say, for instance, atorvastatin 10 mg is part of the NLEM, let's say 2015. National List of Essential Medicine 2015. That becomes part of the price control. Suppose if companies come up with 15 mg atorvastatin, 20 mg atorvastatin, they're all not going to be part of the price control. And given the fact that our manufacturers are very smart, they would come up with all kinds of permutations and combinations in terms of dosage forms and strength, which is what they've been doing in order to get away from price control. So I hope that's clear. Just to give an idea about the Indian pharmaceutical market, currently it's about 150,000 crore worth of medicines, which you can think in terms of 17 therapy areas. So the point that I'm trying to make sure here is the fact that pharmaceutical market is not just a single market, but composed of 17 therapy areas, and each of this can have several supergroups, can be classified into classes, subgroups, and formulation. So as you can see down below, the kind of so-called competition and then monopoly elements can be looked at that level of the formulation. So if you're looking at competition and prices based on the competition, you would actually be looking at the level of formulation. Essentially, the pharmaceutical market is composed of 3,500 markets or 3,600 markets. As a result, as you can see down below, the formulation level, if you add up these two, essentially so the evidence is very clear that 70% of the Indian pharmaceutical market, there's either high or moderate concentration of market power. So only about 30% of the market, there's some bit of element of competition. That's an important point. I'll skip some of it, but just quickly give an idea about the current market share. Only close to about 10% of the entire market, pharmaceutical market, is now price controlled, despite the fact that all the essential medicines are price controlled today. Now, this is despite the fact that if you add another 5%, which is a new set of category of price control based on trade margins in 2019. Using the para 19 of DPCO, the government of India came up with another set of price control measures where they capped the trade margins of about 42 anti-cancer medicines. And if you add these two into account in terms of both, so as you can see, so 15, if you leave out those 15% of the market, 85% of the market, the Indian pharmaceutical retail market, is not price controlled. And that's a fact of life, despite the fact that all the essential medicines are price controlled, and about 42 anti-cancer medicines are also part of it. So that's the larger part of it. Quickly, let me touch upon a few points about patented medicines. Currently, in India, about 5% of the entire pharmaceutical market are patented. These are patented medicine, as you can see at the last column. About 5% of the entire market, pharmaceutical market, is price control, which has a value of about 7,200 crores out of 142,000 crore worth of medicines sold in the market. But having said that, the larger concentration of patented medicine is in 3 or 4 therapeutic areas. And one is certainly, I mean, 1/5 of the entire cardiovascular system of the market is patented, which is really huge, followed by anti-cancer oncology medicines, which is about 6.5%. And then the first one, metabolism, largely to do with the anti-diabetics category. The patented sales percentage is about 8%. So these 3 or 4 categories of therapeutic areas needs a lot of traction and focus in terms of patented medicine. Overall, it's about 5%. But if you look at the top 20 patented molecules in India in July 2020, out of 7,200 crore, about half of them is basically is composed of these 20 molecules. And as you can see, large number of, in fact, about 17 of them, of the 20 molecules, patented molecules, they're basically into the category of anti-diabetics category. So that's an important point to remember. The other point to remember is also, unlike the other countries, in our country, the basic problem even with the patented medicine is also the fact that we come up with all kinds of formulations and combinations. Look at the fixed dose combination within the new patented categories, 1, 2, 3, 4, 5 of them. This is again very unique to the Indian context, which needs further scrutiny. Just to give an idea, there was a talk earlier about the issues around patented medicine, especially if you look at the only CL that was issued in India for sorafenib. So currently there are about 5 brands and about 3 companies selling it. But if you look at the HHI, which is the index, Hirschsprung index, which essentially looks at the concentration, huge, even still now, large monopoly elements. Look at sofosbuvir, for instance, the hepatitis C drug has about 14 brands sold by about 13 companies. Still has large element of monopoly, despite the fact that you have voluntary licensing among the 13 companies. The point to note is, as far as sorafenib is concerned, look at the price difference. In 2011, there was only one company selling it for 220. Now it's come down to about, the least one is about 58 rupees. So that's about 1/4 now. So large reduction because of the compulsory licensing. Now look at voluntary licensing that's happened. In 2015, the first set of player was Dr. Reddy's Laboratory, selling it for about Cipla selling it for about 550 rupees. Now look at the price reduction, just about 410. So the point I just wanted to drive home the point that unlike sorafenib, where it's basically compulsory license-based intervention, the intervention brought down the price by about 1/4. but look at the intervention or market intervention, which is through the voluntary licensing. The price reduction is not so significant. That's the point that I wanted to bring home. I think I'll stop here with just last point about what do we do about price control in the context of patented medicine, given that in the last about 15 years now, we have a product patent system. About 5% of the market is now patented medicine. Now, these are all large element of basically monopoly element. Therefore, we need to really think through much more carefully in terms of intervening in the market, in terms of bringing many of these patented medicine under price control. Now, that's not going to happen easily, because if you go simply by the national list of essential medicine, that's not going to happen, number one. And the second point is about the fact that market-based pricing formula is not the solution. It doesn't really give the patient the kind of relief required, the cost relief required, price relief required. So we'll have to go back to cost plus based pricing formula. I think I'll stop there. Thank you, everyone.
Thank you, Shakti. So we will take up the question after the next presentation. So next presentation is by my colleague, Pratibha Shivasubramaniam. As Shakti told us that there are various exceptions to the price control. So one of the exceptions was the patented medicine. Though the patented medicine poses a very important challenge of high prices, but there were two carve-outs. One is in the policy itself said that we will have a separate policy on the price control, price control of or pricing of the patented medicine. And secondly, they said that even though those medicines which are essential, which are currently under price control, those medicines can have exception from the price control order if there are patent based on R&D carried out in India. But in 2019, through an amendment to the DPCO, the scope of this exception has been expanded. Now that makes it all the patented medicines outside the scope of the price control. So how does it happen? What is the consequences of it? So Pratibha is going to explain to us. Pratibha, floor is yours. Pratibha? Hello?
Yeah, I think, sir.
I'm trying to share the slide. I'm trying to share.
Yeah, please. Yeah.
Ritesh, this is not allowing me to share the slide.
Oh. Just a moment. But I don't see any problem. Maybe you may have to just log out and then rejoin.
No, you may have to. There is something called present now on the right-hand corner. Why don't you click there?
Yeah, that's not giving me permission to share the slide.
Okay, who has to give the permission?
But permission is not required actually. So let me just check.
It says permission is denied to share the slide.
Can you email me? Is it possible to email it to me, Pratibha?
Yeah, I'm just doing that.
Yeah. So meanwhile, can we take the questions then?
Yeah. So let us let Pratibha fixes the slides. The floor is open, so you can direct questions to.
Sir, there are some questions in the chat box. So if you have access, or should I?
You can read out. You can read out those questions.
Okay. So one of them has already been answered by Pratibha. So she has answered it in the chat box. So I'll move with the question of Sanita Maria. So it's to Shaktivel sir. Do you think trade margin rationalization method is effective as it is based on the prices put by MNCs on their first sale?
All right, so I'm not sure where the question of MNC coming into play, because whether it is MNC or the domestic companies, the point is there's an issue, no doubt. But remember, trade margin is only not part of the deal. Trade margin itself is not the basic thing that can reduce the price. Yes, no doubt. To some extent, it can give reduce implications, but a large part of the profit and then super normal profit is charged by the manufacturer themselves. So I think that's something that's not being.
Hello. Yeah.
Yeah, I've got it. Sorted it out.
Yeah. Okay. Pratibha, go ahead.
Are you able to see the screen?
Yeah, it's appearing.
Are you able to?
Yeah, it's appearing.
Okay. Just in case it gets stuck, please let me know.
Yeah, we can see your slides, but you will have to put it in the presentation mode.
I have put it in the presentation mode.
Okay. Fine. I think it's visible. Or do you want me to display it from my side? I have received your email.
Okay, that's fine. I'll stop presenting. So sorry.
Shall we take another question?
Sir, I have shared. Is it visible?
Okay. Okay. Yeah, it's visible. Yeah, go ahead. Pratibha,
Yeah. So just like Gopa had mentioned, today I'll be discussing the exemption under the DPCO and how the amendment has changed certain things. So and what is the impact of this amendment? So basically, para 32 of Para 32 of DPCO, it provides an exemption and from price control. This clause was amended in 3rd January 2019, and it substituted clause 1 of Para 32 and inserted a new clause. And the exemptions were mainly saying that from manufacturers, it was given to two categories. Manufacturers producing new drugs patented under the Patents Act were exempted for 5 years from the date of commercial marketing of the by the manufacturer in the country. Second is all the drugs that are used for treating orphan diseases were exempted from price control. Next slide. Next slide.
Yeah, I have.
So I'm just comparing the old and the current para. The old exemption was provided to manufacturers who are producing patented drugs, but they were producing and which were not produced anywhere else, and which was developed by indigenous research and development. And this exemption was for 5 years from the date of production in India. So there are few there are important points here where that it was the exemption was granted for drugs that were developed with indigenous technology or with indigenous research and development, and second, it was granted for drugs that were produced in India. Now the new version says that manufacturer is producing a new drug patented under the Indian Patent Act, and the exemption is for 5 years, and it is for commercial marketing from the by the manufacturer in the country. Now here there are two points, there are two definitions that are important. Who is a manufacturer? Manufacturer can be the patentee, it can be a licensing, or it can be any person who is producing the new drug and or manufacturing the new drug. Now manufacturing also includes importing the new drug. So even if a manufacturer imports the new drug, he still is considered to be a manufacturer. Need not produce. So secondly, just go to the previous slide. Yeah, new drug is defined is not the new drug definition under the DPCO. New drug definition is taken from the Drugs and Cosmetics Act. Next slide. Next slide.
Yeah, I think it's.
Yeah. So previous slide, Ratish. Yeah. So when we compare the present and the old versions of Para 32, what we can understand is one is the definition of new drugs is under the Drugs and Cosmetics Act, and it is very broad. It includes drugs that are proposed to be marketed with new claims. For instance, new indication, something that is being used, for instance, aspirin, which was tried for blood thinner, or some can be used for pain relief, then it is also considered to be a new drug. Dosage for something, a drug that is sold at 100 gram, 100 mg, can be sold at 50 mg, that is also a new drug. Dosage form, which means your pills, your syrups, etc. So all these are considered to be new drugs. So it's a very broad definition of a new drug. Fixed dose combination of two drugs can be considered to be a new drugs. All vaccines, all recombinant DNA, everything is considered to be a new drug under it's a very broad definition. So when you look at this broad definition from the DPCO exemption for patented drugs, it becomes more murkier, because drugs which are patented with minor modification will also be considered for exemption. For instance, why this is a concern? Because in India, the Patent Act has been devised, or it has provisions to curb evergreening. That is, one drug may have many patents, and this will create a patent thicket. And there are provisions in the Patent Act which prevents evergreening, or which may not allow such patent thickets. But however, recently there are studies in 2018 which says that 72% of the pharmaceutical patents that are granted are for minor modification or marginal improvements. Now, when 72 patents, when most of the patents that are pharmaceutical patents that are granted for marginal improvements, it is these drugs that may seek exemption. These marginally improved drugs may fall under the new drug category, and they can seek exemption from the price control, which would actually defeat the purpose of DPCO. And then the amendment actually will promote frivolous patenting and promote evergreening of patented drugs. Next slide. Yeah, this is an example of one drug, ibandronate, and it is patented by Roche. It has about three patents granted, and there are 13 generic companies which are selling this drug. And the language of this amendment, it does not differentiate between the patent holder and the generic manufacturer. So technically, even generics can seek exemptions. So everyone, regardless of who has patented it, even the generics or the patentee can seek exemption from this provision. Next slide. So the exemption actually may also result in extending various versions of the same molecule. For instance, suppose a manufacturer is planning to market a drug which has got an approval and is planning to market a 25 mg tablet, then he can seek exemption for 5 years for 25 mg tablet. And thereafter, he wants to, he will stop producing that and he can produce a 20 mg tablet or a 50 mg tablet. Again, he can seek exemption because the amendment does not say that how many exemptions you can take from one patent. So, or many patents. So this is quite, it's very vague and it becomes extremely complicated and complex. Then the main crucial question here is, how is the Department of Pharmaceuticals or the NPPA, that is the National Pharmaceutical Pricing Authority, which is going to implement DPCO, is going to ensure that the exemptions are granted only for genuine inventions? Because if a manufacturer is coming with a patent and saying that this particular drug is coming under this patent, how are they going to verify? Are they going to examine the patent applications? Are they going to examine the patent claims? Do they have the expertise? So what expertise, and are they stepping into the patent officer's expertise? So these are quite, so it's also impractical to implement in that level if you look at it. Next slide. So secondly, this amendment does not take into account that grant of patent is not conclusive in India. So it is subject to challenges, revocation. For instance, there is this case, Valganciclovir, which was granted a patent. Then there were oppositions that were filed. Post pre-grant was filed, post-grant was filed, and that was not heard. It went to High Court. There was multiple litigations on it, and it went back and forth. And throughout the period, the patent either got granted, then it revoked, then it was in a limbo. So, there can be different stages in which of patents after the grant. Also, it's not conclusive. There is various provisions in which it can be opposed, and so we cannot say that we cannot. There are these. There are these presumptions of validity and questions that could be raised, and this is not considered by the amendment. What would be the situation in these, when it is opposed or when it is revoked, or about the presumption of validity is not being taken?
I think we lost him.
Dropped off the call, I guess. Yeah.
Yeah, I think we lost her, sir. That's what.
Hello.
I'll just call up here.
Yeah, I think maybe we'll wait for 2 minutes, then we'll open it for discussion.
Yeah, sir, I think we have some questions in the chat box, if it's possible.
Yeah, we can take up those questions. Some of them are answered. Yeah, can you hear us? So let her come back. So before that, if you have any questions at this moment from the chat box, what I could see is that there is a question about one of the key arguments given for patenting is incentivizing R&D. What's your view on availability versus accessibility debate on the matter, particularly about balancing of two key issues? So Shakti, if you could answer that, it would be wonderful. Shakti?
Yeah, sure.
Yeah.
So my short answer is, assuming that if you go by what the companies claim, the multinational companies claim, which comes up with so-called the blockbuster drugs, and assuming that they spend about 13 years of research, R&D, and then if you include all the failures in the process of 13 years, assuming that one molecule comes up, market, and assuming that the companies, if you go by the company's logic and estimate of $2.4 billion, which they seem to be investing in terms of one particular blockbuster drug. Now the question is, should they be incentivized? Yes. If you go by this simple number, yes. But this estimate of $2.4 billion worth of money that's spent on coming up with a new molecule is been junked for a long time. A lot of people, including experts within US and outside US, have come up with a lot of estimates which suggest that it is just about not even 1/10 of what the companies claim to be. So even assuming, now let's assume that it is 2.4 billion worth of dollars to come up with a new molecule. Now look at the worldwide sales turnover of these molecules. In 1 year, if you look at some of the blockbusters, the turnover of in fact, most of the blockbuster drugs, the turnover runs into $40-50 billion a year in just 1 year. In a sense, in 2 or 3 years' time, they recoup the entire investment that they've made. Number one, and then so the question is, why give patent for 20 years? That's number one. And the second major point, which I think in my view is even extremely important, is the fact that the basic candidate molecule which they pick up and develop, they're all basically public funded money. They're all tax funded money. As you can see, most of these new sets of chemicals which are developed later by the company, they all originate from the NIH kind of publicly funded clinical laboratories, both in US and outside US and Europe as well. So the point is, why the company is given this kind of advantage when actually it is the taxpayers' money which is invested initially. So the point is, the society must get the return that it's investing. I'm not sure, is that reasonable enough?
Yeah. I think this is there is a huge, huge gap between what they claim and what's the reality. Okay, so therefore, R&D expenditure is often being used to pursue the monopoly interest. Even that's very visible in the case of COVID now. Even though COVID vaccine or COVID medicine research are lot of public money poured in. Okay, no private company has put substantial percentage of money for COVID research, but still companies are not ready to give up the patents or even trade secrets or that kind of intellectual property, right? So
well, let's look at Remdesivir.
Yeah.
Now, Remdesivir is a classic example. There was a question about whether CL should be compulsory licensing should be issued during the COVID. Absolutely, certainly. In fact, India and South Africa recently, about 3-4 days before, went to WTO asking for the waiver of these WTO rules in the presence of the pandemic. So Remdesivir is a classic case for compulsory licensing. Number one. Now, the other point about Remdesivir is the fact that it is already a drug which is already been used for other tested in other for anti-HIV conditions. So, I mean, if Gilead is going to come up with new use of the existing molecule, that's not going to be allowed as part of the 3D provisions under amended Indian Patent Act. Gopal? Hello?
I think so.
Am I audible, Gopal?
Yes, sir, you're audible, sir. I think Goba, sir. Goba, sir, you're not audible. Maybe I think you may have to unmute. But,
Okay, can I take the other question? There was a question.
yes, sir. Yes.
So there was a question about the National Pharmaceuticals Policy 2012, where they were supposed to set up a separate committee for deciding the pricing of patented medicine. Yes, that's true. In fact, after 2012, not one but several committees were set up. 2 or 3 committees were set up. Unfortunately, all their recommendations came out, and then it was junk. It was all junked by the government themselves. So it didn't see the light of day. Unfortunate truth as on today, 2020. Yes, so the question is, will not Doha Declaration pave the way? Of course, Doha Declaration should pave the way for compulsory licensing, number one. And the amended Indian Patent Act also has a provision for compulsory licensing. And remember, these are supposed to be acted upon during emergency. We have a pandemic which is happening. It's a once in a century pandemic. If this is not emergency, health emergency, what not?
Right.
What else is the emergency?
True, sir. Sir, shall we get back to the presentation? So, Pratibha has rejoined. Hello. Hello.
Hello.
Yeah.
I'm so sorry. I think there was a power cut, so the internet just cut off.
Okay.
So I was talking about that there is the patent term and the exemption need not be coterminous, and the exemption could extend or exceed the patent term. And just like there was some discussions and some questions relating to how price control, whether it's allowed or whether it's controlled, whether there is any connection with TRIPS. And price control, TRIPS does not talk about price control, and so it's a flexibility. But allowing such an amendment under DPCO is actually surrendering critical policy tool. We're just reducing our policy space. We could actually even bring in patented drugs under price control. And even the Patent Act has provisions for local working and also providing medicines at affordable costs. And this DPCO amendment, it actually undermines all these public health objectives. Even the compulsory licensing provision and the government use provisions, they have, especially compulsory licensing provision has grounds for local working and also excessive provisions for excessive or unaffordable prices that we can grant compulsory licenses. However, this will be, though the amendment doesn't stop compulsory license, this will be a defense from by the patentee saying that the government has allowed this exemption, so I can fix the price according to according to the patentee's decision. And the amendment actually again doesn't incentivize indigenous R&D or local working. It promotes import monopoly, and it will also deter transfer of technology by the Patent Act, which is required by the Patent Act. And so it is also not clear whether the same drug can have different commercial marketing dates. For instance, different manufacturers, the exemption is given to manufacturers. Different manufacturers can have different manufacturing dates. So we are not sure that each and every manufacturer throughout the patent term may have some time or the other exemption for the drug under throughout the patent term throughout the running of the patent term. And so throughout the running of the patent term, the price control of this patented medicine would not be possible. And secondly, there is a scenario that under the Drugs and Cosmetics Act, new drug is considered new for 4 years, whereas the exemption is given for 5 years. So exemption will run for more than just for 1 year. More than there is a chance that exemption will run for one more year beyond the 4-year period that is considered that considers the drug new, and sometimes it can go to 5 years. So this new drug and the exemption, new drug period that is 4 years and the exemption period that is 5 years. That connection has not been well thought of by the amendment, and this has been discussed that it promotes import monopoly. Next slide. So the amendment as such is against the objective of DPCO, and it is not based on any evidence. And as per the Pharma Policy 2012, it mainly says that controlling price control of patented medicine has to be after the consultation with stakeholders. But we did an RTI and we found that only Niti Aayog, Health Ministry, and some high-level meeting has been conducted. They say that the Niti Aayog report has been, there is a report by the Niti Aayog. We sought for the meeting minutes in which they took the decision for this amendment. They refused these meeting minutes to us. And we haven't got the Niti Aayog report as well. And providing these, so apart from the unilateral move of the DPCO, we also feel that these providing medicines at an affordable cost or price is also a constitutional mandate. And these amendments, they violate Article 14 and as well as Article 21. So next slide. I think I conclude here, and sorry for the break in the presentation.
Kind of, what you call God's intervention, right? Beyond your control.
Yeah.
So having said this, it clearly shows that 3 or 4 points comes out very clearly. First is that price control is an important tool considering India's current health system, which in a way to give some sort of relief to the patients, but there are problems with regard to the way in which the price is controlled. First issue. Second, it provides a lot of exemptions. These exemptions virtually nullify, to a great extent, the effects of price control, because all essential medicines are under price control. But then you allow, okay, fixed dose combination can go out of the price control, or even a patented drug can goes out of the price control, or a new drug delivery system can goes out of the price control. So all those things basically shows that if an intelligent manufacturer can exploit these provisions and put their products or his or her products outside the scope of the price control. And the third issue which is coming up recently is that, as I told you, the DPCO, and exceptional circumstances or in the public interest, government can actually control the, put a ceiling of the MRP of any medical products. So the problem with the model of price control is that it is based on simple average. Okay, if there is only one producer, what happens is that if you take the simple average, that would be the same price. So therefore, often when it came to the fixing of the price of the stent and other products, they looked at what is the landing cost, or what is in a way sort of what is exactly the reasonable price, and try to fix a reasonable ceiling on the price of those products. But now what we have seen, the aim is to never control the margins of and not the put a ceiling on the MRP. So this to an extent, okay, brings down the trade margins, but it never controls the MRP, because the producer has the complete freedom to fix the MRP. So if the producer tomorrow fixes a high MRP, then the price will remain very high. So therefore, this method may not work in the long run. So having said this, now let me open it for discussion. So most important thing, today's focus is on the 2019 amendment, and which basically open up a huge exemption which a manufacturer can exploit, and brings out it goes against the uh, rational, or is against the approach of the Patent Act, because the Patent Act under Section 83 says that a patent is granted not to enjoy import monopoly. Okay, then it also says that local working is an important condition. Otherwise, it constitutes a grant for granting compulsory license under Section 84. Now you are saying that okay, these drugs are outside the price control, so you basically allows a monopoly, whether it is produced in India or imported, they're all outside the price control. But most importantly, this promotes, frivolous patenting. And as of now, what we are aware that one of the public interest groups, All India Drug Action Network, already approached challenging this DPCO amendment in the Delhi High Court. And at the same time, there are companies who sought price control, citing various patents. There are around 7 or 8 petitions are also pending in the Delhi High Court, seeking exemption from the price control, which have been denied by NPPA, citing one or other reasons. So that is where we are. Now the floor is open, and the people who want to take the floor are welcome. And please mention the person to whom you are directing the question. Thank you. We can have around 10 more minutes, right?
Yes,
For questions. Yeah.
yeah, sir.
Go ahead.
One of the questions is from Siddharth Sadashivam. Why DPCO cannot control the price of patented drugs, I believe.
Could you repeat the question?
Why DPCO cannot control the price of patented drugs?
Pratibha, please.
DPCO should control the price of patented drugs. It is because of this amendment that they are being given an exemption under the DPCO, that now the patented drugs are granted an exemption from being under the price control. And actually, this has been a sudden move from the Department of Pharmaceuticals. And because till now they have been discussing with the stakeholders, and last year suddenly they have brought out this notification.
I am Milind Sathe. Can I speak?
Please go ahead.
Yeah. Now see the scenario here. On one hand, the DPCO is being made toothless, and at the same time, there is no suo motu mechanism available at the patent office despite filing form number 27 as to which patent is open for compulsory licensing. In short, what is happening is we have a very well laid out elaborate patent act, but it is practically useless. And here afterwards, I think we should send emails to the health ministry and to all the ministries from all over India, stating them that any such decision cannot be taken unilaterally. There has to be a member, there has to be a representative from public, there has to be representative from the generic industry, there has to be representative from hospital industry. Earlier, 6-8 years back, an attempt was done wherein the members from railways and insurance companies were included into the committee. Such things should not happen. Those who are affected and those who contribute to the solution should become member of the such committee, and this should be sounded to health ministry, to DIPP, to DPCO by sending them email or from all over India, so as to let them know that they cannot have a haphazard way of making rules and executing them, which is prejudicial to Indian citizen at large. Thank you.
Thank you. So that's a comment. So anyone else?
Okay, I'm Milind Sati. Again, I want to make a comment that they should also disclose the way in which the pricing shall be fixed, if at all they are going to fix the price, because the purchase parity factor or government subsidization of an individual plays a great role here. In India, the spending to the medicine is primarily through private pockets, which is not the case outside India. And therefore, we cannot have principles, we should not accept the way in which the prices are fixed if they are similar to the way they are fixed abroad in developed world. We are on different platform, developed world is on different platform. So we cannot have a pricing phenomena or pricing procedure, which is similar to developed world, because we are not same.
Yeah. So let me ask a question to Pratibha as well as Shakti. Either of you can answer. This was raised also earlier. There is this report in media that the US is exerting pressure on India to do away the way in which we invoke paragraph 19 of the price control order. Under the DPCO, paragraph 19, this is for the benefit of many others who may not be familiar with the paragraph 19. The Government of India invoked paragraph 19 and put a ceiling on the MRP or ceiling of the retail price. But there might be some difference. There might be earlier, before GST days, there would be, sale tax and other things. But now there is a GST, so you have a single rate. So you put a ceiling on the MRP, right? Then everybody knows that what exactly the price. So often in the medical devices, when it comes to medical devices, much of these margins were actually pocketed by the hospitals or the retailers or the not exactly by the manufacturers. The stent used to be sold at around 15,000 to 20,000 rupees, but which was sold to the consumer or to the patients around somewhere between 55,000 to 100,000 rupees. So the reduction of margin in a way will bring down that exploitation by the hospitals. But the worry is that this may, in the long run, the exploiter become from the hospital, it may become the manufacturer, because manufacturer has the freedom to fix the very high margin. So what I am trying to ask is that there is a move by the US, it is out there in the public domain, to telling Government of India not to put a ceiling on the MRP, but you control the margin. So what is the implication of if Government of India agree to such a demand from the US?
Can I say something?
I think it is asked to Shakti and Pratibha. Hello? Hello, are you there, Shakti?
I think Shakti sir has issues. There's a power cut failure. That's what he just said.
Pratibha around?
Pratibha is around, yes.
Pratibha or Shakti? I think I can see the Shakti. Shakti is still around.
Sir, can I say something?
Yeah, please go ahead.
See, in my articles which were published in India and abroad, I have stated it several times that no company, even in developed world, has ever submitted the books of accounts for a particular product, which would enable the governing or the regulatory body in that country to audit and assess the real costing. The crux is here. See, this is a sophisticated way of allowing manufacturing companies to provide inflated costings to the government and asking government to control only the margin, not the costing. This is, here there is a game. If at all you really want to control the pricing, then government authorities must have means to assess the costing, whether the costing submitted is realistic or it is inflated one. If there is no such mechanism available, government will simply accept whatever costing that is given by the authority, given by the company, and they will try to fix the margin. The real game, the profit would go in the costing itself.
Yeah,
So there
but
has
yeah, but there used to be a days where government of India had its own posting mechanism to have find out the posting and put a ceiling on medicines based on the cost based price
absolutely
control
correct.
mechanism.
Absolutely correct. But as you are saying, day
As
after
of now,
day,
it is not there. Yes.
exactly, they are all becoming toothless. We are having excellent laws and regulations which cannot be implemented. What's the use of such laws?
Yeah, as of now, you are right. No, we know that the what should be the exact mechanism, but we do not have those what you call net and bolts are in place to ensure the proper implementation of even DPCO or even the Patent Act.
It
Uh,
is not. It is not only the absence of appropriate nut and bolts. There is a lack of political will.
Ultimately, it's boils down to
Proposing such a unilateral move to make the DPCO toothless is an indication that there is no political. See, here there is a clear-cut segregation of public goals and public good and private good, to put in simplest words. And whenever there is a difference, whenever these two do not coincide, whenever the political good or political goals and public goals when they don't coincide, it is a manifestation of absence of political will.
Yeah, absolutely. So I know I fully agree with you. So is there any other questions or comments regarding the presentation, even though there is some technical failure in which we don't have the people who made the presentation online right now, but still we can raise these issues. Okay, so some of us can try to answer some of those questions. Otherwise, we can mail them and then get back to you. So the floor is still open. So we will take another 6 more minutes maximum and then conclude it. So any more questions?
So before we finish, I must congratulate you. You have done an excellent attempt, and through your mechanism of this presentation, I think you should request all those who have attended this seminar that they should write to DPCO, they should write to Public Health Ministry, they should write to DIPP, that they should take public in confidence before making such a move, which is going to impact the public pockets. Where we are spending from our own pockets.
Yeah,
And I
definitely. I
think
mean, these are researchers. They should write their papers, assignments, and publish it in the various academic journals, newspapers, op-eds, and directly to the government also. Yeah, in the coming
we should make noise about it.
Yeah, absolutely. Any questions or any clarifications?
So no further questions in the chat box.
I don't think so. Anything? There is something. No, I don't find any. Okay, there is a question that do you think we have a different agency to control patented drugs and biologics? So a small information. Actually, Government of India initiated. There is something called a mechanism for you can say price control of the patented medicines. Okay, in 2008, then around 2010, I think they published a discussion paper, but nothing has moved forward. But the how the patented medicine comes into the price control, there are two ways in which the price control DPCO comes into play. The first one is that some of the medicine which are designated as essential medicine as per the national list of essential medicine, there might be patent. Okay, till date the situation was different. Essential medicines are mostly the substantial percentage of the essential medicine globally from the, if you look at WHO essential medicine, they're outside the patent protection. So, but if you look at the recent list, as I say 2019, around 12 plus medicines are patented. Patented medicines. So if those medicines also designate in India as essential medicines, so you have a patented medicine which are part of essential medicine list, but patented. Okay, some of the medicines would be patented. So how do you fix the price for that? You cannot put a simple average of all the brands because there is only one producer. Okay, so you need a different mechanism for that. That's not there right now. Government has the policy space under the paragraph 19 to fix that. Then you have the paragraph 32 amendment, which says that, okay, all the patented medicine, whether it is produced in India or abroad, whether it is imported or locally manufactured, whether it is the result of R&D in India or elsewhere, it doesn't matter, it's all exempted. So that paragraph 32 in a way exempt these medicines outside the scope of price control. Okay, so that's why it's a problematic paragraph. Then comes the issue of the approach of the Patent Act. What the Patent Act says that patent does not mean an import monopoly, and Patent Act also says that a patented article should be available at an affordable price. If there is a failure to make it available at an affordable price, constitute a ground for granting compulsory license after the 3 years from the date of grant of the patent. So that's now in a way that is still valid because it's a law, but your policy contradicts. The DPCO is an executive act. In a way, say, oh, if it's a patented act, then there is no price control. So in a kind of negatively impacting the approach of the clarity given by the Patent Act. So that's the problem, and the government tried to come out with a came out with a discussion paper in 2010, etc. How to fix the price of a patented medicine through a particular formula. But the problem is that formula. I'm just concluding. If that, can you hear me?
Yeah, we are clear.
Yeah. So if you apply that formula, the price you are getting is still very high than the price you introduce through a competition through a compulsory license would be much more lower. So I'll give you one example and conclude that. Okay, you can negotiate a price with the patent holder. So one of such negotiations happened in Egypt for sofosbuvir. Okay, so this medicine for a 3 months treatment, the cost was 84,000. So the Gilead Sciences, which holds the patent, agreed with the Egyptian government to provide the medicine for $900. So that means around 90% less than the original price. Fine, but 900,000 is still very costly. When the generic production started, that medicine is available, around $160. Okay, or 300 to 160 to $350 price. Okay, so that is through a voluntary license. If you really bring down the price through a compulsory license, then the price would have been less than $100. There are companies who do not have a real but producing the generic version are selling at less than $100 this medicine. So this is the difference. So we do not have an agency, but there were attempts to have a mechanisms to fix the price of some of the patented medicines through a particular formula, but that formula still makes the price very high. So in India, you don't need in a way a mechanism to fix the price. Then what you should need is to have a very liberal approach to the compulsory licensing, or the government should issue very liberally the compulsory license to all the essential medicines if it is patented. So that's not happening. So therefore, the amendment to the paragraph 32 is very problematic. So let me stop it here. So Ratish.
Sir, only one thing
Yeah.
I want to suggest. See, there is another provision available in the Indian legal scenario, and that is known as NLEM. That is known as a list of essential medicines. So if we develop adequate pressure whereby government is forced to include a patented medicine into the national list of essential medicines, then automatically it will come under price control. But here, I don't feel there is a political will to cap the price of the patented medicine so that it can be rendered affordable. If there would have been political will, the NLEM would have been another avenue by which the patented medicine prices can be controlled. Thank you very much.
Thank you.
Okay, I think it's time to wind up the session.
Yeah. Yeah.
So I'll request Srinath to kindly propose the vote of thanks.
Yeah, and
Yeah.
still after we have 90 people, so
Am I audible, sir?
Yes,
Very much.
yes.
Yeah. Honorable Director Dr. Basi sir, today's chair, Mr. Gopakumar sir, resource persons Shaktivel sir, and Miss Pratibha Subramanian ma'am, Shiv Subramanian ma'am, and all our invited guests. It is my privilege to have been asked to deliver a vote of thanks this evening. Firstly, I, on behalf of IUCI Paris University and the organizing committee, extend a very hearty vote of thanks to all resource persons for gracing their valuable knowledge, and also to the participants for raising the various questions as well as comments. It was all very wonderful, and we have learned a lot. And I also extend my gratitude towards our director, sir, Dr. Basi sir, as well as our moderator, Dr. IG Radhi sir, for making this webinar possible. Last but not the least, all the participants, thank you for registering to this webinar and also participating in this webinar. And finally, I would request all the participants to kindly fill the feedback form, which would be sent to you by mail or by other ways. And you have to fill the forms in order to get the certificates. And the suggestion that you would be providing in the feedback form would be referred to when we would be conducting our next webinar. Thank you all.
Thank
Thank
you.
you. Thank you.
How will you be sending the certificates, you said?
So we'll send the feedback form by email. So you just
Okay.
need to fill those and you'll automatically get the certificates.
Thank you. But how will you come to know what is my email?
You have registered.
Okay. Thank you.
Thank you all. Thanks a lot, Sir Gopakumar Sir, Dr. Shaktivel, and Pratibha Subramanian, Shiv Subramanian, to accept our invitation and be part of this endeavor. And we also hope that more such programs would be conducted where your help and support would definitely be needed. Thank you all for joining.
So shall we leave now?
Yeah. Thank you. Thank you all.
Yeah, but that option is not appearing here to leave. I think the host has to discontinue. Automatically all will go.
You see in the center between camera and that microphone.